Okay. Good morning, good afternoon, good evening, wherever you might be. Welcome to our 17th Migraine Masterclass. It gives me great pleasure to be here with you tonight. As you can see, I'm not Dr. Shadi. I look a little bit different. Dr. Shadi had an emergency, and he does apologize profusely for not being here with us tonight. However, I was so excited for this event tonight because of obviously our great guests, but also the subject that all of us are interested in, because we always remember those who we couldn't help. So it gives me great pleasure tonight to have two amazing guests and to welcome everybody who's joined us. Our event will be the usual. We're going to have the first session, and it's going to be with Dr. Jennifer Robley. If you have any questions, we'd like you to put the questions in the Q&A, and I'm going to be giving the questions, or I'm going to be actually transferring these questions to Dr. Robley at the end of her session. So if you have any question, put it in the Q&A. And then the first session, as I said, is going to be around 40 minutes, and then some question and answer. And the second is going to be with Dr. Maria Khan from the UAE, and it's going to be the Pfizer Satellite Symposium. And again, we're going to have the questions for Dr. Khan at the end of her session. So again, this is the 17th masterclass. Thank you for being with us tonight. We have one more to go for this series. So this is our third session, or our third intake of migraine masterclasses. And the last one is going to be in June. It's going to be 14th, I think, of June. We're going to make some announcement on that. So quick reminder that questions are in the Q&A, and that if there are any general information that we'll be sharing, it's going to be in the chat for you. We will start tonight with Dr. Jennifer Robley, and Dr. Jennifer Robley is an associate professor at Barrow, and that is in Phoenix. It's Phoenix, Arizona, right, doctor? Can you hear me?
Yes, you've got it. That's correct.
Yeah. So it's a university. She is a professor, associate professor at the University of Arizona. When I was looking at the CV, I don't know where to start. Starting from the chapters in books, or the national committees, and the research that is done. When I asked Dr. Robley about what is her main interest, she did tell me that her passion is difficult to treat migraines, so refractive headaches, and status migrainosus. And that, as I said, these are the ones we remember. These are the patients that we feel that we've done everything, but they still are not getting relief. And they are the ones that possibly are most difficult to treat. And having an expert like Dr. Robley with us tonight is an honor and a pleasure. So I leave the floor to you, and I will see you at the end of your presentation to just give you again the questions that we see, or to transfer these questions to you and see what you would like to tell us about these. Thank you.
Wonderful. Well, thank you for that great introduction. So let me just get my screen shared. All right. So as I was introduced, I'm Dr. Jennifer Robley, and I work at Barrow, which is in Phoenix, Arizona. And I'm going to be talking about how to manage patients with a lot of different severe symptoms in migraine. There's a lot of different approaches that I could have taken with this. Oops. Here are my disclosures, just so you know. And I will mention some things that are off-label. And of course, some of the availability of certain medications are going to vary globally. So I apologize if I'm talking about something that you don't have access to. So I'm going to give some example cases as we go through the different steps of the talk, and also talk about some of the spectrum of symptoms in migraine. And part of what I wanted to do today is talk about not just how we manage migraine, but when someone's coming in and their severe symptom is something other than headache, what do we do in those cases? So that's where I'm going to be focusing today. All right, so first off, let's just talk about the spectrum of migraine symptoms. So migraine actually has four phases. We often just assume that we're talking about the headache part when we're talking about migraine, but there's four possible phases. Now, not everyone is going to have all of these phases, and really any of these phases could theoretically happen on their own. We obviously know the most about the headache and the aura phase, and we're starting to know quite a bit about the premonitory phase, which is sometimes also referred to as the prodrome. We know a little bit less about the postdrome phase, however. So you may see someone who has just an aura. An aura is seen in about a third of patients with migraine. So remember, you do not need to have aura for it to be migraine. The premonitory phase is an interesting phase. So we're going to get a little bit more into that one in detail too. But first off, just to give you an example case of someone who has all four of these phases. So envision that you have a 25-year-old in your office. She's been having headache for about 2 years. She tells you she has attacks that are happening about twice a month. But when she has an attack, it's really taking a good period of time. So her typical attack course is that for the first 24 hours, she starts to feel just really fatigued. She feels irritable. As the day goes on, she starts noticing that she yawns a whole bunch. And then the next morning when she wakes up, she often will start to experience an aura. Her aura is a pretty classic one. She'll get a scintillating scotoma. That'll go on for about, 5 to 10 minutes. And then she gets into the headache. And if she doesn't catch that headache early enough, it's going on for 36 hours. It's, your classic sort of 8 out of 10 headache. It's pulsating. She has it on both sides. It's a little bit worse to that left side for her. And she gets a bunch of photophobia and nausea. And she just feels unwell during the whole thing. As the headache starts to dissipate, she's still left with just this postdrome phase where she feels exhausted and just completely worn out. And that can go on for an additional day. So even though the headache itself is 36 hours, she's basically got an additional day she's adding on to the start and the end of the attack. This is unfortunately common, and we don't talk about it a lot when we talk about our diagnostic criteria. And we don't really talk about it much when we're talking about how to treat headache. So first off, let's get into this premonitory phase. So this can even be days before you have your actual headache phase start. And it's interesting because often these are mistaken as symptoms that might be a trigger for headache, when in fact what they're telling you is it's a warning sign before you have the headache start. So for instance, you could have poor concentration and fatigue. You might start to notice changes in your mood. So you could have depression or irritability. But you can also have an increase in your mood. I've had patients tell me that they suddenly feel this really excited, happy feeling. And for them, weirdly, that means that they're about to get a migraine attack. Classic symptoms that you can get during the headache, like photophobia, phonophobia, osmophobia, all of those can start to precede the migraine attack itself. Often neck pain or stiffness starts to begin before the actual headache. You can start to have a lot of just poor sleep. You might have insomnia. You might be extra tired. And yawning is a classic symptom that can actually start to happen. You can get food cravings. Often this is sweet cravings. You can start to have other GI symptoms like nausea, diarrhea, constipation. You can also have urinary symptoms where you start to get urinary frequency, or you may notice that you're excessively thirsty. Now you can envision that, let's say someone comes into your office and they say, every time I eat chocolate within 6 to 8 hours, I get a migraine attack. I think I need to stop eating chocolate. And you've got to pause and stop. And do you really tell that person that they're not allowed to have chocolate now for the rest of their life, that they're still having migraine? And the answer is probably not. We don't have good evidence actually that it's actually a migraine trigger. And what they may be having is a premonitory phase where they're having sweet craving, and for them that sweet craving is the chocolate. And so that's actually their warning sign that the migraine attack is about to start, not that they actually are causing a migraine attack by having the chocolate. Same thing, I'll have many patients tell me that, oh my goodness, I went out into the bright sunlight and all of a sudden I had a migraine attack. Well, it wasn't that the sunlight caused the migraine attack, it's that they were already photophobic and they went outside, they noted that photophobia, and then soon after the headache started. So it starts to change how you might approach counseling someone on trigger avoidance, because what you might be trying to do is tell them to avoid something that's not actually a trigger at all, but rather it's just part of that warning sign for migraine. So it does start to change how you might approach managing these patients with these symptoms. Now, the aura phase, as I mentioned, happens in about a third of patients. We have typical aura, which 90% of the time is going to be visual, but we've also got sensory aura and language aura. And then there's less common types of aura that include brainstem aura, hemiplegic migraine, and retinal migraine. And these are caused by cortical spreading depression that happens across the cortex, where you get this change in a wave of electrical activity that's followed by a change in blood flow. The way that you try to decipher whether or not you think this is aura versus something else like a TIA or like a seizure is you use the ICHD-3 criteria. And so aura should have at least 3 of. The symptoms should evolve over 5 minutes. So you can imagine if it's a visual aura, it's sort of like this expanding scotoma. You can have successive types of aura. So it starts with one and then moves into the next. You can have an aura that lasts anywhere from 5 to 60 minutes. That's a classic duration. You can have it be unilateral, and a language aura, by the way, does count as a unilateral aura. You can have positive symptoms. You can imagine if you have a scintillating scotoma, you may have the scotoma, which is a negative symptom, so a lack of vision in a certain area, but around it you have all those scintillations. That's positive. So that's something that's been added in. That's something additional that you're seeing. Or if you have numbness, it's that tingling on top of the numbness. That's your positive symptom. And then if it comes with an associated headache. So you should have at least 3 of those to feel pretty comfortable that it's an aura. All right. And then we've got the headache phase. So the headache phase is what we know best, but remember, it can come with so many other symptoms. As part of the criteria, we know it can have nausea, vomiting, photophobia, phonophobia. Don't forget about osmophobia. That's pretty common in migraine, and it's pretty specific for migraine. You can have kinesiophobia, where it's that you have this issue with any sort of movement. Movement just makes you feel worse. Dizziness is very common, and that might be vertigo, but sometimes it's just a vague dizziness. Brain fog, where you have problems thinking. Neck pain is a really common part of it, and people will assume that it means that their headache is actually from the neck, but sometimes it's actually the neck pain is actually from migraine. Remember all those pathways. If you look at this picture here, you have all of that going down into the trigeminal cervical complex. So remember, we do have cervical as part of the migraine pathway. You can also have autonomic symptoms. So some patients may start to experience a gastroparesis. They might have, just in general, a lot of more GI symptoms, urinary symptoms. They have cranial autonomic symptoms. So you're allowed to have something like mild ptosis. You're allowed to have some of those more mid-face symptoms like congestion, rhinorrhea, your eyes might water. They're going to be often milder than what you'd see in a TAC. And usually they're going to be bilateral, but you can definitely have them as part of migraine. And then finally, we have the postdrome phase. Often that lasts for hours into a day or two. And this is colloquially called the migraine hangover. This is just where you feel tired, you have an inability to concentrate, your mood might be lower, you might have some of the residual symptoms like nausea and light sensitivity. You could have more of that ongoing brain fog, and you just kind of feel awful. And so while your migraine attack is seemingly over, again, it takes time to recover from it. So generally, the way that we approach treating all of these symptoms is using what we recommend in general for treating migraine. So we have our preventive treatments, we have our acute treatments, and then we have the neuromodulation devices, which overlap. So for preventive treatments, just as a quick overview, we've got our non-specific pills. That could be things like topiramate, propranolol, and triptyline. We've got a whole bunch of different medications that are actually antihypertensives like candesartan, lisinopril. Depending on where you are in the world, you might have flunarizine. I don't have access to that. You have valproate. So we've got a lot of different options there. You have the CGRP pills, so the calcitonin gene-related pills. These are the GPANTs. So you have rimegepant, which is known as Nurtec, and then you have atogepant, which is known as Qulipta. Then you have the self-injections. These are the CGRP monoclonal antibodies. And these are the ones that are the subcutaneous injections. So you have arenumab, which is Aimovig, fremanezumab, which is Ajovy, galcanezumab, which is Emgality. And then there's injections that you can do in clinic. So you have onabotulinum toxin A, and then there's also nerve blocks, which the evidence is a little bit not as strong for, but it is something that's very commonly used. And then finally, as an intravenous treatment, we've got eptinezumab, which is Vyepti. So I would recommend before you consider someone having no other options, they need to try basically everything on this list. What you have for your non-specific pills is going to vary by region and by which guideline you use, but generally I recommend every single patient should go through basically all of these medications one by one. Usually it's for a 3-month trial, unless they just do not tolerate it. Start low and go slow. And when you're using the medications, you can consider doing combinations. So for instance, there is some evidence that combining Botox with one of these CGRP medications may have a synergistic effect. So do consider doing some combos, even though we don't have a lot of evidence for it for the other medications. I do think that that is worthwhile. And then don't forget that all patients need to have an acute treatment. And you can always consider the neuromodulation devices if you have access to them. And then once you've tried all of these things, that's when you start to go outside of what we have good evidence for. And that's a whole talk in itself that starts to get way beyond what we have good literature, and you start to get into a little bit more of that art of medicine. So let's talk a little bit more about aura. So envision that you've got a 32-year-old female. She has a migraine attack about 2 to 4 times a month. Her attack usually starts with these sort of zigzags and checkerboard patterns. And often it starts on one side of her vision, but eventually it spreads and it encompasses the whole vision. And that goes on for about 20 minutes. As that starts to sort of wear away, she then gets numbness and tingling that goes into her face, into her tongue, and down into her hand on that left side. That goes on for about another 15 minutes. And then it may or may not be followed by a headache. So this would be a pretty classic example of an aura. There's positive symptoms, there's unilaterality. They're going on for that, 5 to 60 minutes. They're successive. Sometimes it's followed by a headache. So you can see that this is very classic, very fitting with a migraine aura. And so these are the actual diagnostic criteria for how you diagnose an aura. And these are what I mentioned in that previous section. And so these come from the ICHD-3. So really you want to have some combination of B and C. It needs to be one of those 6 different types of aura that I've already mentioned. And then as I mentioned, you want to have at least 3 of those symptoms that I mentioned. And of course, you need to feel pretty confident that you don't think it's some other disorder. So there are some other types of aura. So you can have aura that's called persistent aura without infarction. So that's where you do have a migraine aura. It's typical, but it's now gone on for at least a week. You should have neuroimaging in that case that shows that it's not an infarction. And of course, you need to feel pretty confident that you don't have another diagnosis. So this, for instance, would be someone where they have that scintillating scotoma that starts, it's seeming their usual, but that scotoma just doesn't go away, and it's now been a week or more, and it's still there. You've done imaging, there's no stroke. And so that's what we're talking about in this case. And then there's also what's called migraine aura status. This is an appendix diagnosis. And so this is where you have migraine aura, so it's filling the typical diagnostic criteria for it. But you've now had, within at least 3 days, you've had at least 3 auras. So do they just keep happening, more rapid succession than what you would expect? And again, this is a time when you should be getting some sort of imaging. You want to make sure that you're not seeing that there's stroke. You want to make sure that there's not something odd like a vasculitis, etc. Especially in an older adult, you want to make sure that there's nothing like an amyloidosis type process happening. Now, what do you do to treat aura other than just treating the underlying migraine disorder, which would involve all those things that we've just talked about in the previous section? So we don't have a lot of good evidence for it. There is a good consensus from the American Headache Society that magnesium can help with treating aura. So if you're doing that acutely, you can use IV magnesium, 1 gram to 2 gram of magnesium sulfate. There's a little bit of evidence to suggest that divalproex may also help with migraine aura in addition to the headache. And then otherwise, you're using a little bit more anecdotal or low-level evidence. Ketamine has been looked at being used that way. You can use ketamine as a compounded nasal spray or as a IV medication. You can actually make it into tertiaries as well, which are like lozenges. With ketamine, the the data is pretty variable and it's inconsistent. It has been studied specifically for hemiplegic migraine. And we do sometimes try it, but again, it's hit or miss, and we don't have great data on it. You can try the neuroleptics. Again, whether or not they're going to help, it's always hard to know, but it's something that often you're going to try acutely for migraine anyway. So something like, you know, a prochlorperazine, chlorpromazine, that type of thing. You could always give some IV methylprednisolone. So using the steroids may help, but again, evidence there is low. There's a great review article from 2015 that was done by Rosen and Continuum, and he made some recommendations of trying things like acetazolamide and IV furosemide. And again, those are more based on theoretical evidence than good evidence. But I have to say, I've tried it and sometimes I've had a little bit of success with them. And then if you have a patient where they just tend to be really prone to aura, and that's a really disabling symptom, one thing that I've tried is using lamotrigine orally for these patients. Obviously, this is not something that's going to work in the acute setting because you've got to actually build up the dose, but it is something that I've tried with some success. All right, so let's talk next about what you do when patients are really having bad GI symptoms. So let's say we've got a 25-year-old female. She has migraine attacks about 8 days a month. And every time she has an attack, she's got really severe nausea and lots of vomiting. It's hard to keep her medications down. And when you probe a little bit more, you find that she's prone to early satiety. So in addition to having all that nausea and vomiting, even in between the migraine attacks, it sounds like she's having some GI symptoms where it may be consistent with something like a gastroparesis. And we do know that patients with migraine are more prone to gastroparesis. All right, so again, when you're considering all of these medications, particularly for the acute treatments, which is what we're really going to get into, you want to consider how you should be choosing your medication when a patient has a lot of GI symptoms. You may also want to consider it for the preventive, especially if they have GI symptoms in between the migraine attacks. So this might be where you go more for rimegepant because it's an orally dissolving tablet, or a self-injection, clinic injection, or IV medication, because all of those are going to avoid having to go through the gastric process. And a neuromodulation device might be another nice option here. So nausea is really common. We see it in about 73% of patients. So first off, you want to look into what they're using as their acute treatment. Is it working? Are they keeping the medication down? How quickly does it work? A good goal is if the medication isn't working in 1 to 2 hours, then you want to try something different. That's usually how I decide whether or not to move on. Now, for those really difficult refractory patients, you're going to get the best that you can get. But for most patients, that's a good goal to have. Then you want to consider what you're using for an anti-nauseant. So you don't want to just give them a triptan, but what are you doing to help actually control their nausea? So ondansetron, which is Zofran, can be quite effective for patients. However, some patients will have a side effect where they actually get headache as part of the side effect. So that can be counterproductive, obviously. Metoclopramide is another great option that I use all the time. You can use 5 to 10 milligrams for that. And then there's other medications that are also anti-dopamine, like the neuroleptics. So again, that's going to be things like promethazine, prochlorperazine, chlorpromazine. Sorry, I have a cat that's trying to join me right now. And we don't have this in the US, but domperidone can be quite effective. And then finally, you want to consider if it's a prolonged attack or if they're having a lot of vomiting with it. Are they getting sufficiently hydrated? And that might be when you want to get someone into urgent care or the emergency room to make sure that they're getting rehydrated. All right, so consider the route. If they're having vomiting, then we want to avoid oral. You may want to avoid the orally dissolving tablet, just depending on, you know, how they tolerate it. It might be just putting anything in their mouth is going to be enough to trigger the vomiting. And you might be able to, you know, get it in and get it absorbed before they actually vomit. But you'll want to base that on the patient and how quickly they're vomiting. Nasal injection and rectal are all great options in these patients when they're vomiting. If they have gastroparesis, and a good sign of that is if they have a lot of vomiting or they have a lot of early satiety, then again, you want to try to avoid oral medications. And I would advocate for oral being avoided as much as possible for both your acute as well as for your preventive medications. Here, the orally dissolving tablet might be a good option, so you could consider it in these patients. And then nasal, injection, and rectal, of course, are all going to be great options as it bypasses the issue with the gastroparesis. So basically, to summarize, if you have a patient with nausea, you can try oral, but if they're going to vomit it back up or they're going to not tolerate it, then you may want to go more for the non-oral. And you want to make sure that they have an option for an antiemetic. And again, that antiemetic could be oral or non-oral. Now, if the nausea comes with vomiting, that's when you should try to avoid the oral more consistently and make sure, again, that they have a non-oral antiemetic. And of course, if the patient gets admitted, then we're going to do parenteral treatments, and we may want to consider some IV hydration if there's been a lot of vomiting. So here's an example of some of the medications that I've mentioned with some of their dosing. And this will be posted, so you can always steal these slides later, but these are kind of the spectrum of things that I use, except for the domperidone, which we just don't have access to in the US. All right, let's talk about sensory sensitivities next. So envision that you've got a 45-year-old male. He's got a history of chronic migraine that's been going on for years. And while the headache is painful and he has headache basically every day, his most bothersome symptom is that he's got severe photophobia. He basically lives in the dark. He has to go out into the light. He's wearing sunglasses, and he doesn't know what to do. It's just completely debilitating for him. So how do you manage it when headache is not the most bothersome symptom for a patient? So we've got a lot of different examples of what I mean when I say a sensory sensitivity. So photophobia would be what this person's experiencing, but some people are very prone to noise. I have one patient where basically he just goes around wearing noise blocking headphones all the time. Some patients are extremely smell sensitive, so it's hard for them to go out in public because any little smell, any perfume, soap, food is just nauseating and headache inducing for them. And then some people are very prone to feeling worse headache by movement. So it's like a kinesiophobia. So just activity is very limited for them and they can get very sedentary. And so how do you manage these things? And so first off, for photophobia, a lot of patients will first try the blue blocking glasses. There's companies out there that make these. And if you go to an optometrist, they can often add a tint basically that's blue blocking into the actual lens itself. For phonophobia, a lot of patients are going to try things like earplugs. Osmophobia, that's a tough one. I mean, basically they end up doing trigger avoidance. And then for the kinesiophobia, usually I try to send these patients to a physical therapist who knows how to just slowly get this person, basically some exposure therapy to movement and see how we can get their brain to rehabilitate itself to tolerate movement better. In all of these patients, you want to make sure that they're on preventive treatment and you want to try to optimize that preventive treatment. I will say, just like sometimes I've tried lamotrigine in patients with aura, patients with really severe versions of these symptoms, I will sometimes try the lamotrigine here as well. Completely off-label, completely anecdotal, but it is something that I will try. These patients are often quite debilitated by the symptoms. And so doing something like a cognitive behavioral therapy or mindfulness to help with some of the mood changes that can come along with this and the stress of it can be quite helpful because often these patients are going to have a concurrent anxiety or depression. And then one thing that, again, it hasn't been studied, I don't think I have any good study to refer you to for it, but something that I'll try is a gradual exposure. So for instance, if you have this patient with severe photophobia, them hanging out in the dark every single day, wearing their sunglasses with any light, they're actually reinforcing this photophobia, right? And so what you might do is have them start with something as simple as in the morning before the sun comes up, go outside without your glasses, let the sun come up and see how long you're able to tolerate it for. Do it right to the point where you're at the max of your tolerance. And then keep doing that until you can tolerate more. And then maybe eventually it's that you're going to start with the lowest watt light bulb that you can find. And you're going to slowly see if you can get higher and higher watt light bulbs that you can sit by for longer and longer durations. And you just have them work with a very gradual exposure to rehabilitate their brain to be able to tolerate it. It's one thing I've found that can help, but you need a patient who's very engaged, who's willing to do that. Our physical therapists and our pain psychologist at Barrow are great and that can help us with that. But otherwise, it's something that you're doing and can be quite difficult and a lot of work. And they really need a lot of guidance because they can get frustrated because this is not a quick process, it's slow. All right, let's talk about dizziness next. So imagine you've got a 39-year-old male. He's got a history of episodic migraine. But in addition, there's episodes of this rotational vertigo that can last 20 to 30 minutes. Sometimes the attacks of migraine and the vertigo co-occur, but they can both occur separately. So this patient probably has vestibular migraine. So to be diagnosed with vestibular migraine, you need to have had at least 5 episodes. You need a history of migraine, be it with or without aura. And usually the vestibular symptoms are pretty moderate to severe. They're debilitating, and they last anywhere from 5 minutes up to 3 days. And they should be associated with some of these following features. So if you have the headache, it should be a headache that's pretty typical of migraine. So you need at least 2 of unilateral, pulsating, moderate to severe, or aggravated by routine activity. That comes from the ICD-3 actual criteria. Headache associated with photophobia and phonophobia. They don't have nausea listed, since often you're going to get nausea with vertigo anyway, or visual aura. So they want you to have at least one of those headache features that are with at least 50% of the episodes. And then it shouldn't be better accounted for by another diagnosis, be it a headache diagnosis or a vestibular disorder. So now some of the vestibular symptoms that you're going to see in these patients is an internal vertigo. That's where you feel like you're moving. Remember, vertigo is basically an illusion of movement. You can also have external vertigo. That's where you may not feel like you're moving, but you feel like the world is moving around you. The vertigo may be positional, so it's when you get up from bed or stand from sitting, those types of things. Visual vertigo is a really classic symptom that we see with this. And so complex patterns or seeing a lot of movement will induce the vertigo. And then finally, head motion. So turning your head, looking up, those types of things might be vertigo inducing. First off, you want to make sure that they don't have another disorder. So rule out something like Meniere's disease, BPPV. And then usually for prevention, you're going to use your typical options. But one thing that I really like in these patients is venlafaxine. I find it helps with the vertigo. I also find that it helps with some of the anxiety that comes with it, because vertigo tends to be very anxiety inducing. Some off-label things that I sometimes will try is gabapentin and acetazolamide. I've even had them use acetazolamide as a PRN medication for this type of thing. And there's actually a study that's looking at using galcanezumab for vestibular migraine. When you're using acute treatments, again, you're going to use the typical things, but there have been some small RCTs that were done specifically with zolmitriptan and rizatriptan. So you may default to using those first, but really any of the rescue medications would be appropriate. And the most important thing for these patients is to get them in with physical therapy, and they need to have vestibular rehabilitation to help them learn how to cope and how to manage with these symptoms. And they need to not just do the physical therapy when they're with the physical therapist, but they need to also continue doing their home exercises, and they need to know that this is going to be a long path. This is not going to get better in a few weeks. So you need to help them set expectations. Okay, so now you've got this patient, and he was lost to follow-up. He comes back 5 years later, and now he says that he's got daily vertigo. Sorry, daily dizziness. It's a little bit more vague now. He just kind of constantly feels like he's on a boat and he's moving, and he's wondering, what do I do? Like, what happened? Why did this get worse? And so this is something that you should be aware of, because it's often going to co-occur in patients with vestibular migraine or with any other cause of vertigo. And this is something called persistent postural perceptual dizziness, PPPD or triple PD. So here they've had persistent dizziness for at least 3 months. The symptoms are going to be on most days. The severity can definitely fluctuate, but it's impairing. It's very debilitating. It's often worse with upright posture, with movement, and visually complex patterns. So they get a lot of that visual vertigo. But it's not truly vertigo that they're having now. It tends to be more vague. I find the most common description I hear is that they feel like they're on a boat, or like there's just kind of this vague unsteadiness, wavering. Often when you watch their gait, they can do things like tandem, etc., but they're just very cautious. They need a lot of prompting. They're very uncomfortable with it. So these patients need a lot of vestibular physical therapy, and they may benefit from some cognitive behavioral therapy as well. This is basically like a functional neurological disorder of dizziness, as best we understand it. Basically, you can imagine that they were experiencing vertigo, and instead of their brain sort of improving and getting used to it and getting better, especially if they were lost to follow-up and didn't get good treatment. Now their brain has sort of, rehabilitated itself in the wrong direction. So now any movement is just not tolerated, and it's become a pervasive symptom. So these patients are going to need a lot of rehabilitation to help with these symptoms, and it's not uncommon for it to coexist in patients with vestibular migraine. And the hint is going to be that their dizziness is more vague and it's more constant. And often it seems more disabling than what you would expect for what you're seeing on their physical exam. And it's going to come with a lot of that visual vertigo. They're just very intolerant of looking at things. They often have a lot of other things like light sensitivities, I find very common in these patients. All right, let's talk a little bit about brain fog. So for some patients, especially those patients with chronic migraine, headache is one thing, but they feel like they just can't think. They feel like they're just dumb. And so let's say we've got a 34-year-old female. She's had migraine for the past 2 years, and she's now got this background daily headache that's about a 1 to 2 out of 10. So she feels like she's never truly headache free. And 8 days a month, she's got a full-blown migraine attack. And she feels like over the past couple of years, she's had this increasing cognitive impairment. She feels like she's got word finding difficulties. Her concentration is poor. I feel like she just can't remember people's names. And it's really, it's stressing for her because she's worried, am I getting a dementia? What's happening? So you do something like a MoCA or an MMSE, and she gets 30 out of 30. So there's no blatant evidence that she's getting some sort of dementing process. So what is this? When we know that you can have migraine-related cognitive impairment, there's definitely been evidence of this. It seems to be particularly affecting attention and concentration. There might be some effect on language. And while you can definitely have it ictally, so part of the migraine attack, there are patients who have it interictally. And I find that's particularly true for the patients with chronic migraine, where they have some degree of symptoms all the time. While it is more common, I find if they have a mood disorder or a sleep disorder, it does not require that they have one of these. It can be purely from migraine itself. And the good news is there is at least some evidence that it can improve with treatment. So again, you want to look at preventive treatment. So you want to go through all of those different options and try different things. Now, they may be less tolerant of some of the medications that are sedating or something like topiramate, where they're going to have some cognitive side effects, but that doesn't mean you can't try them, because at the end of the day, this is from migraine and not from something like a dementia. So you can try those, just go slow and be gentle with it. And then make sure you're screening for depression, anxiety, sleep disorders, including sleep apnea, and that those are also getting treated. Because if those are not treated, then you may have ongoing sort of that pseudodementia type picture. All right, and then finally, I want to talk about allodynia. So envision that you have a 32-year-old male. He's had episodic migraine for the past 8 years. And he started noticing over the past year or so that migraine attacks have increased. They've gone from maybe 3 to 4 days a month, and slowly over the past year or so has gotten up to 8 days a month. And now he's having this new head tenderness in between the attacks. And so if he just kind of touches his head, he said it feels like his hair hurts. It's harder for him to wear his glasses, like right around the ears. It hurts to have any pressure there. So this is allodynia. So when we talk about central sensitization in migraine, often the correlate to that is allodynia, and then also you can have hyperalgesia. When we talk about peripheral sensitization, that's more thought to be that throbbing pain that we feel in migraine. And so it's really whether or not the sensitization is happening out in the periphery or happening centrally in the brain. So the official definition from the IASP is that central sensitization is increased responsiveness of nociceptive neurons in the CNS to their normal or subthreshold afferent input. So translation, nociceptive neurons, those are basically your neurons that sense pain. They're becoming hyper-responsive, and it no longer just needs their normal sort of stimulus that turns them on. Now even a subthreshold stimulus is going to be able to turn them on. So remember, normally a nociceptive neuron is going to turn on in response to something that's painful. Well, now it can get turned on by something that's not painful, like touch, i.e. allodynia. So allodynia, by definition, is pain caused by a non-painful stimulus. While the hyperalgesia, that's still that you have a painful stimulus, but it hurts more than you would expect it to hurt. So for instance, that little pinprick that you might do on exam is now suddenly very painful. So what does central sensitization do to migraine? Well, we think it might help make that chronification more likely to happen. So you're more likely to have more frequent headache. You might start to get that background headache. You might start to get just overall worsening symptoms. We think some of those cranial autonomic symptoms may relate to central sensitization. Worsening of your sensory sensitivity, so things like photophobia and phonophobia may worsen. And then having allodynia is a sign that there's central sensitization. And so again, these are patients where you definitely want to have them on a preventive, and any of the types of preventives would be appropriate. And really, the goal is that when a patient has about 3 to 4 migraine days in a month, that's when you should be starting treatment. If you're like at 2 to 3 days and they're already having allodynia, especially if some of it's intra-ictal, that's when you may want to start a preventive even earlier, because that patient is going to be higher risk for progressing to more frequent migraine attacks and even to chronic migraine. So allodynia is a good sign that you may want to be more aggressive with your treatment early on. All right, so we've talked about a lot of different things. We talked about the phases of migraine and all the different treatments that can come along with it. We've talked about the different types of aura and some of the ways that we can try to treat it. We've talked about dizziness, be it vestibular migraine or something that often comes alongside of it, triple PD. We've talked about allodynia. We've talked about GI symptoms, including nausea, vomiting, as well as gastroparesis, the different sensory sensitivities, and then cognitive symptoms, and all the different ways that you can try to treat these when you're focusing not just on the headache, but all the other symptoms that can make migraine disabling. And that can be, for patients, sometimes they're more a disabling symptom than the headache. So I'm happy to take questions, and thanks for having me today.
Thank you very much. I mean, I haven't seen your presentation before you presented it today, so I had a lot of questions, and I'm very, very happy that I did get a lot of information that is relating to my questions. I will start with some questions, and I can see some questions in the Q&A. Thank you very much. This was really touching on a lot of things that we see with our patients, very, very practical. And I think you gave us tips that we can actually use in our practice. So if anybody has a question, please go to the Q&A and put a question. And I will start where you ended, which is allodynia. So allodynia is the one that I usually don't know what to do with it. Someone is getting severe pain from something as simple as the cold. If they go out and there's a little bit of wind or a little bit of a breeze, they feel it as if it's slapping them in the face. And I usually don't know what to do with them. Are there any, for you, preferred first line? The first thing you think of when someone has that severe allodynia and they have tried many things or whatever, when you see them the first time, is there something that pops to mind immediately?
Well, those patients, I am more likely to try nerve blocks on, and I'll try to target to the place where they have their allodynia. I like Botox for these patients, and I will do follow the pain. And sometimes I'll go off label and really try to target follow the pain with more dosing than what's typically recommended. So another thing that I'll try is with the Botox, if it's a lot of like scalp allodynia, so up here, there is actually a theory that if you do Botox along the coronal suture, that can actually be beneficial. The theory is that there may be these tiny little nerves that come actually from the dura area up through that. And so you may be actually getting those peripheral nerve endings there. And so I'll often add like coronal line injections. And again, I don't know if it's that I would do a really good job selling that, I'm going to target the places where you're having a lot of this tenderness and that's going to help, or is it that it's actually doing it? But that's the other thing is, often we see that people like, naturopaths have this really great results when you're like, they're literally giving homeopathic medications. Why is this working? And I think part of it is that you got to use the placebo response too. So really sell what you're doing and why you're targeting where their pain is. I do have one patient where they didn't truly have migraine, but they literally they couldn't tolerate cold. Like I'm talking, I live in Arizona where it's hot, and this person would go around with a cap on because they just couldn't let their head be affected by air. And I put them on a CGRP monoclonal antibody, and that helped. and they're now tolerating cold closer to a normal person. Not perfect, but pretty good. And
And
so
the G-pants, have you tried G-pants as well? I know CGRP with Botox usually work very well.
yeah,
What
yeah.
about?
So I mean, yeah, I mean, I tend to have a more aggressive practice. So I'll often overlap the different CGRP medications. So I will use Qulipta and an antibody together. I will use, say, Qulipta and let them use Pura and Nurtec. So I will combine things like that. And I do find for patients who are CGRP medication responders that they tend to do better with the overlap medication. Again, I think time will tell how safe that really is. So far, it seems like it's safe, but just know that we don't have that down perfectly yet.
Um, I'm going to go to, it's very interesting because I can see a lot of questions popping up. So I'm going to
Great.
just go with a couple. So this question is great that we have you today, because I know this is a product that's not available in the US, but is available in Canada. And Dr.
Mhm.
Robley did practice in Canada. We're talking about beta histine or Circ or beta Circ.
Okay.
What do you think of that as an option?
I mean, I think it's reasonable to try for dizziness. I don't think I ever found it amazing, but you
Mhm.
can definitely try it. There is some evidence for it. So you can definitely give it a try. But yeah, the limited experience that I had when I was practicing there, I didn't see it be life-changing, but that might have just been my personal experience. Yeah, and
Mhm.
I only did my own practice there for 3 years, so it's not like I had a long time to use it.
And like the other question is, if they don't have that, they have no other option. That's the only thing that is available other than physiotherapy. But is it because we have to treat the underlying cause, which is the actual migraine?
Yes,
That,
absolutely. Do not
that
forget to treat it. Yeah. So
that
it's so important.
this is just a symptom. So beta histine just works on one part, but that's not what we're trying to do here for
Exactly.
the case that you showed us.
Yes. Yeah. So absolutely you want to treat migraine. This is another type of setting where I might use lamotrigine. I like to pull lamotrigine out for basically non-headache symptoms. I find that's useful. I also like to do the same thing with acetazolamide. I find both of those are great. For some reason, gabapentin works in these patients. Not all of them, obviously, but I am more likely to try gabapentin in these patients, even though the evidence for it for migraine in general is not great. So those are some of the things that I will try where evidence is low. But I've had some good experiences with it. And then, like I said, SNRIs seem to work well for these patients. And I think because it's getting at some of the underlying anxiety that comes with it, so those can be really useful. And in general, if you have a patient who has the triple PD, there is some evidence that using an SSRI may also be helpful. And again, I think that's getting at some of the anxiety that's very, very comorbid in these patients.
And do you, I also thought it was very, very relevant when you said that they start with a little bit of dizziness and then becomes disabling. Do we know
Yes.
why this happens? You said that this, instead of their body getting used to it, it actually accentuates it or becomes
Yeah.
even sensitive to it. Do we know why?
I mean, I think it's basically the opposite of why we recommend things like cognitive behavioral therapy. They start to do reinforcing behaviors. They become fearful, very cautious, and all of that, I think, just reinforces those pathways in the brain until it spirals out of control, and they're non-functional as a result of it. And so then you have to slowly undo that process and get them functional again.
Totally agree. I had another question earlier on that talked about neuromodulation, and I know that
Mhm.
in very severe cases, patients they just want to try anything and everything they
Yeah.
have in their arsenal. What is your experience? What do you think?
I think unfortunately neuromodulation works great for episodic migraine, and I haven't had a great experience with it for the more severe chronic migraine. There's the random exception, so it is always worth trying. And it's a pretty benign, safe treatment as long as you can actually have access to it and the patient can afford it. But unfortunately, it just does not work as well for those chronic patients who are veering towards the refractory end. That's not what I wish my answer was, but it is.
And What about supplementation, magnesium?
Again, yeah, it's another thing that I'll add on as an adjunct. I do like magnesium in particular, especially if they've got a lot of aura type symptoms, and I will have them even add it into their acute treatment at home. So it can be useful for that. And there is evidence that magnesium helps with both headache as well as with aura. So it's a nice, safe option to use. Um, I find of the supplements, I really like riboflavin, but you've got to give it time. So you've got to give it at least 3 months. And again, it's probably going to work better for those patients in the episodic migraine category, but it doesn't mean it can't work in the other patients as well. So it's always worth trying. It's just probably not enough. We're going to use it in your chronic patients as something that's an adjunctive treatment.
I have, since the beginning, we have had a very, very active attendee here, Hind. I think I have 5 or 6 questions from this attendee who's very, very keen to hear more and more and more and more. Some of these questions are about access. It's wonderful. But if it's anything to do with access, I'm going to say disparities and access and all of that. I suggest, I really like these as questions, but I don't think it's what we're discussing today. And I think it's a great subject for a future webinar. But there are some questions here. Do you think that there are differences within your patients? The question is exactly, how do cultural differences impact the management of severe symptoms? And how can you your approaches according to what's happening culturally in with your patients?
Yeah, probably when I was in Toronto, I had more exposure to the cultural differences because there's a little bit less of a spectrum of cultural. In Arizona, basically, I see patients who are, just Caucasian, white, and then I see a lot of patients who are Hispanic or Latino. That's probably the 2 most common populations that I'm going to see. And other than trying to manage if there's a language barrier, really the difference for my Latino patients is just making sure that, especially if there is that language barrier, that I still try to educate them because they're going to have a harder time accessing some of the resources that are in English. And then otherwise, it's just making sure that I'm giving equitable access so that they're getting the same care, even if there is that language barrier. But in Toronto, it was harder because I had patients that were from all different cultures, and you really did have to take into account different things. And so certain people are going to be more likely to just want you to tell them what to do. And, in our training nowadays, we're told you really want to make a decision with the patient. And so that's one thing that you take into account is deciding where your line is of how comfortable you are just suggesting you do this versus having that conversation. My default is I want to have a conversation with patients and say, here's the various options. Here's how you might try to make the decision. What are you more comfortable with? But there are some patients where it's either cultural or for some of them, it's also that their, just their knowledge of medicine makes them very uncomfortable making the decision and they just do want to default to you. And so in those patients, I do try to have my sort of default answer of here's what I would do. And are you comfortable with that? And so for those patients, that's what I'll usually do is I'll still try to get their assent, even if I'm not asking them which they want. I'll be like, here's what I think is the best option for you. Is that something that you want? And are you comfortable with that? Do you have questions about that? Do you want to hear about the other options? But otherwise, as long as there's nothing that they consider a contraindication because of their culture, there's not a whole lot that I'm going to change other than just making sure that they feel comfortable in how we're making that decision-making process. I'm still going to try to give them all the same treatments.
I think you're the perfect person to answer this. We had 2 questions that are really more related to your practice, having practiced in different countries. So you were able to help us with these questions. Acupuncture, other like
definitely worth trying. It's something that's going to be safe. It's great because you can use it even in your pregnant patients. Again, in your more severe patients, I find it's going to be something adjunctive. Really in your severe patients, you're using a combination of things. No, there's often no one thing that's going to work as your patient starts to get into that refractory state. versus in a patient who's, mild, like let's say they've got, 3 migraine attacks a month and they're not keen to start a medication. Acupuncture might be a great choice at that point as the go-to therapy, as that's more preventive as a non-medication option. So again, you want to know who your patient is for whether or not you're saying yes or no for it. And it doesn't mean, if your patient comes in, they're chronic migraine and they've never tried a medication and they really don't want to try a medication, you can't try it, but I think it's unlikely to work in that patient.
You talked, and I love that you talked about nausea and vomiting, because I find a lot of patients never get offered anything.
Yes,
That
it's so common.
And it's sad, and it's kind of dismissing something that is really, really disrupting people's life.
Yes,
It affects them
it can
much.
be their most disabling symptom.
Exactly. And when you talked about ondansetron, metoclopramide, domperidone, all these options, do you also, you said that you do combine, do you also combine these?
Yes, I will. And sometimes I'll actually give them steps. So for instance, as long as there's no reason that you're worried about a prolonged QT, I'm pretty comfortable with patients using Zofran often.
Mhm.
Versus if we're getting into the neuroleptics, you want to start to counsel them on the risks of being on a daily neuroleptic. So I try to have them use it less often. I have a very, very, very arbitrary cutoff of aiming for less than 10 days per month. And so, if your Zofran isn't working, that's when you might use, say, your prochlorperazine. But again, there's some patients that are going to need it more than that. You kind of just work within what they're comfortable with. I mean, I have some of my refractory patients, I literally have them on a daily neuroleptic. So olanzapine is an option that I very much like. I'll use it for status migrainosus. It's one of my favorite treatments there. And I have the occasional refractory patient who I have them on daily olanzapine. And so if you are going to, you just want to make sure you're doing that extra monitoring. And that includes things like, their lipids and their weight, that they've been counseled on the risks of movement disorders from it and all that. So you can do it more often. You just want to be careful. And then sometimes I'll pull some of the other treatments out. So you'll look to some of the other things that we use for, say, chemotherapy-induced nausea. So there's aprepitant, for instance, that I'll try. So yeah, there's definitely some trial and error there. For patients where they have a lot of gastroparesis and a lot of autonomic symptoms, one thing I'll actually try that, again, totally off label, there is no study for this. I borrowed this from someone that I trained under, but I'll try carbidopa. I don't know, it often helps.
This is the first time I've heard this one, so I'm gonna write it down.
It is a totally made up thing. Yeah, I'll try 25 milligrams TID and I'll let them use it daily if they kind of just have constant nausea, especially in that like sort of POTS-like patient. Yeah. So, and again, I think it's just something, it's acting on dopamine in a different way, and maybe that for that patient, that's what they need.
Yeah, I think this is very interesting.
So again, the moral of the story is you get creative and you look at what theoretically makes sense, and when evidence is lacking in what helps, you borrow some of the anecdotal and you keep track of it, and at some point someone needs to do a study on it, because
Yes.
I'm not the only one who does it. I know other people in the autonomic world do it. And so at some point we do need some data on it, but it is something that gets used.
I think we're now down to our last question, and I love this question because it says, once they're okay, what happens? Do you discharge them back to their GP? Do you continue care? What do you do once someone is no longer a difficult patient? Do they continue to be your patient? How do you step down once they are?
Well, first off, I like to see that a patient has been headache-free or nearly headache-free on treatment for at least 3 to 6 months before I'll get them off. And I will definitely keep them through that process in case it comes back. And, once I've had them off, I still want to have them come back at least once. And then often I'll give them the option, do you want to come back in a year just as a check-in, see if things are okay? Do you want to just do it as a PRN? And so I'll leave that part often up to the patient. When it comes to things like Botox, if I have a patient who's had like a 100% response to Botox and they're not getting any wearing off, what I'll often do for that patient is move them to, instead of every 12 weeks, I'll move them to every 4 months. And if they're still not getting any, Either I'll stop it or move them to every 5 months and see how that goes. You can do the same thing for eptinezumab. Instead of doing it in the next 3 months, try 4 months, see how they're doing. For the CGRPs or the injectables, you could try instead of in 4 weeks, let's do it in 6 weeks. So you kind of just extend it out. And part of what I'm seeing is, are they going to wear off? And I don't want to get them so far off that it's just totally other system and I throw them back to the way they were. But can you sort of just slowly wean it down and monitor? If they're on multiple medications, don't just keep adding medications. Even for a patient who's not doing great, the medication isn't working, take it away. I have patients who come to me and they're on like 5 different medications and they've got a 9 out of 10 headache every day. And I'm like, did any of these take you out of your hands? Like, are these doing anything? No, let's do a total reset and we'll start fresh. I'm getting you off everything.
Exactly. You're at 9.
So it's okay to stop a medication. Some patients will choose not to. They'd rather stay on a low dose of something, and that's totally okay. And in terms of whether or not I send them back to the family doctor, some of it is practical. So some of it is how crazy my clinic is. Do I have space at this time to be seeing patients who are in a good space? And some of it is how much the patient really struggled, how likely are they to have a relapse? How hard was it to get them there? What are their other comorbidities? Are they a more difficult patient? Is it a medication I'm continuing that I think their family doctor may have difficulty with? So for instance, it's one that's going to need prior auth and their family doctor isn't someone who's comfortable with that. So then I may continue seeing them just so I can continue doing the prior auths. So it's going to really vary from patient to patient.
Thank you very much. Again, I was so excited to be an attendee, and I got so lucky that I got to speak to you and ask you about your practice, and I'm very, very grateful, and I'm sure our attendees tonight have learned a lot about these conditions. I also know that you have a beautiful podcast with the Association of Migraine Disorders that talks about everything you need to know about migraine with aura. I know my colleague, or our colleague, Kylie Petraka from the Association of Migraine Disorders has already put a link to that. Thank you very much. It has been a pleasure, and we're looking forward to having you again on our webinar. Have a very, very good day.
Thank you. It was a pleasure to be here, and I hope you guys have a good rest of the talk.
Thank you very much.
All right. Take care. Bye-bye.
So thank you for everybody who has put questions. I could see that the questions are still coming. Some of these questions we have answered. So if I haven't answered your question, it's because we have answered it in previous webinars. And we do have recordings of these webinars. They are available on the IVPN website. So you can go there. There's a library. The resources you could see in the chat, there's a lot of resources that are available through also the Association of Migraine Disorders, resources that you can also use with your patients if you need some resources. So if you have any question going forward, please put it there. And if I haven't answered it, please, again, join us again to see if some of these questions can be answered, or go back to our library, and I'm sure you will find the answer. So I have my next guest. Our next guest is Dr. Maria Khan. And Dr. Maria, I don't know if, Dr. Maria is here. Thank you very much for joining us tonight. Dr. Maria is in Dubai at Rashid Hospital. And I mean, if you know what's going on in headache and neurology in Rashid Hospital, you will know that there's an amazing achievement that's happening in terms of reducing wait times for patients. The quality of care that is being provided is unbelievable. So Dr. Maria is Dr. Khan is the perfect guest for us tonight because of the great results that they have. And she will be sharing her experience, and she's going to be our guest tonight for the Pfizer webinar. And she's going to talk about Nurtec and how the experience they have and the clinical trials that support its use. Welcome, Dr. Khan, and it's a pleasure to have you with us tonight.
Thank you very much. So that was a fantastic talk. that all of you had the pleasure of hearing, including me. Lots of great learning there. My task is much simpler. What I'm going to share with you is mainly focused on one of the medications, which is one of the newer medications that has hit the market not too long back. So we live in great times for migraine. I remember when we were training, not well, almost like a decade ago, we didn't have much options for migraine. All the medications that we had were adopted from other other neurologists on the panel would agree. They were medications that we had adopted from other diseases, so we were using anti-epileptics to treat migraine, we were using antidepressants to treat migraine, we were using antihypertensives to treat migraine, and we were using non-steroidal anti-inflammatory pain medications to treat migraine. So very little migraine-specific medications were really available. And then we got lucky, and we entered an era where now we have medications that are specific to migraine. So today I'm going to talk about a migraine-specific medication. And the beauty of the medication is that this is one of the first medications that has been introduced as both a preventive medication and an abortive medication. So a lot of the medications that you heard about in the previous talk, and a lot of medications that you are familiar with, are either used either to abort an attack of migraine, or they are used to as preventive medications. And this is this is the first medication that has been introduced to work as both an abortive and a preventive medication. Now there are others in the pipeline that are being pitched like that. So I've received an honorarium for this talk, and the medication that I'm going to talk about is rimegepant. I'm going to talk about three studies in particular on rimegepant and what the evidence is suggesting, and how this medication came to be approved, and what sort of evidence is there for us to sort of give us this confidence in the medication. So the first study that we're going to talk about is a study that was done to test the effect of rimegepant for acute migraine treatment, which means for abortive use. Now, we know that the current treatments, I wouldn't say the current treatments, because now rimegepant is a current treatment, and there are others that are besides rimegepant, that they had limitations. So what were some of those limitations? Those of us who treat migraine, or those of us who suffer from migraine, they know that the migraine medications have tolerability issues. So, triptans, for example, they can have adverse effects. So a lot of patients complain of chest tightness when they take these medications, flushing, and those kind of symptoms are there. Some of the patients, they complain that when they take triptans, they get this sudden feeling of sort of an exploding head feeling, and sometimes they feel that they need another rescue medication even when they have taken one abortive treatment. A lot of times when people take abortive treatments, they end up with medication overuse headache. So for example, they would take an abortive treatment, it would work for a few hours, and then they would need to take another one. Or if they take an abortive treatment on one day, and then they would require it the next day because the headaches come back. And if they are taking it on more than 10 days in a month, then they are automatically at risk of developing what we call a medication overuse headache. And for those of us who treat migraine patients on a regular basis, we know how complex some of these headaches become, and how difficult it is to detoxify some of these patients when they've developed this. And then, of course, we know that there are cardiovascular risk factors that may put these patients at risk of certain abortive treatments. And there's this fear of prescribing, triptans to some of these patients who have significant cardiovascular disease. So we know that there are cardiovascular and other limitations that are there for the acute migraine treatments that exist. What about other things? So we know that triptans were considered, they were the only specific migraine treatments, to be honest, for the acute treatment of migraines. And we know that they were not obviously appropriate for all patients. One, because of the effects we talked about, and then they were also not sufficiently efficacious in, about about a third to 40% of the patients. And then, the number of hours that they were effective also varies. So for some people, it would work for a few hours, and then they might need to repeat a dose. And that left patients very dissatisfied with the kind of care that they were getting. Also, there were emergent adverse effects within the 24 hours that these patients were experiencing. So because of these limitations, of course, there was a niche for better medications for aborting a typical migraine attack. Now, this is where research led us to this molecule, which is your calcitonin gene-related peptide. Now, calcitonin gene-related, how do we know that this is an important molecule in migraine pathophysiology? Well, the studies were telling us that people have resting CGRP levels, and these resting levels suddenly sort of go up when people suffer from migraine attack. This CGRP is a pain signaling neuropeptide, and it is a potent vasodilator. And this CGRP is released from trigeminal sensory afferents and the spinal trigeminal nucleus. And we know that these are very much involved in the pathophysiology of migraine. We also know that studies have shown that plasma levels are elevated during and outside of migraine attacks in people who have migraine. And then there are also studies that have shown that if you infusing people who have migraine with the CGRP would trigger an attack of migraine. So when all of this data was combined, we concluded that CGRP is clearly involved in the pathogenesis of a migraine attack. Once we had reached that point, we knew that if we could somehow block the CGRP at its receptor, we could, stop this entire cascade of a migraine attack. So that's where rimegepant comes in, which is a CGRP antagonist, or it blocks the receptor for this calcitonin gene-related peptide. How does it work? Well, the receptor gets blocked. There's a selective binding of the receptor, and it does not produce the vasoconstrictive effect, which is what causes most of the side effects that are experienced. And it does not lead to the medication overuse headache, which is one of the concerns with the triptans that we talked about earlier. There is an inhibition of vasodilation, which leads to the headache part of the thing, but it does not produce the vasoconstrictive effect. It inhibits neurogenic inflammation, which is another important aspect of the migraine pathophysiology. We know it's a very complex pathophysiology without going into too much detail. So it inhibits vasodilation without causing vasoconstriction. It inhibits neurogenic inflammation. And the third thing it does, it inhibits an exaggerated pain signaling. So through receptor blockade, this rimegepant or Nurtec will produce these three effects, and that's mainly the mechanism of action of the medication. Now, this brings us to the first study that I'm going to discuss today, and it was a double-blind, randomized, placebo-controlled study that was done across 69 centers in the US. It included patients with history of migraine for at least a year. And there were around 700 patients that were randomized to each arm. So the active arm or the rimegepant arm had around 700 patients, and about the same number of patients were in the placebo arm. Rimegepant was given in a dose of 75 milligram as an abortive treatment. There were two co-primary endpoints. So one of the endpoints was pain freedom at 2 hours. So that is what was measured. And the other was freedom from the most bothersome symptom. So whatever the patient considered as the most bothersome symptom, whether at 2 hours the patient was getting relief from that or not, was what was measured. And in the results, what they found was that with rimegepant, 21% of the patients got pain freedom at 2 hours, as opposed in the active arm or with rimegepant, as opposed to only 11% in the placebo arm. Freedom from the most bothersome symptom also significantly higher in the rimegepant arm, 35% versus only 27% in the placebo arm. Now, you might wonder, why is the placebo working? And this is something that you will find across the board in most of the migraine or headache studies, that the placebo does have an effect. Because you see, whenever you're talking about pain relief, there is always an element of placebo action that is there. And you will always find that the placebo effect has a good proportion of patients who respond. So these patients, obviously, because it's a double-blind study, they were getting a medication, and because of the placebo effect of the medication, there was some response that was there. But the effect of the active medication was above and beyond, and significantly more in the active arm. The secondary endpoint was pain relief at 2 hours, and that again was significantly more in the rimegepant arm, 59% versus 43% in the placebo arm. So this was the acute treatment, one dose without a rescue medication being given, and these were the outcomes that were being measured. Now, what about sustained effect? I mean, did the effect last, or or was it just that immediate 2-hour effect, and then they required something else? So when they looked at the patients who did report that they achieved pain relief at 2 hours, which was about 59%, 71% of those continue to experience sustained pain relief. And this is where, and through 48 hours. And this is where rimegepant, this idea that the medication could be used as a prophylactic medication came into place. And we'll talk about that in the future studies. So the medication was not requiring a rescue medication. So there was a pain relief, and that effect was sustained. So those who did achieve pain relief, they continue to have a sustained effect over the next 48 hours. Okay. This one also is pretty much showing you something similar. So, what you're seeing here is that within 15 minutes, some pain relief had already started. So there's a fast action that you're able to see. And then the effect is sustained over 24 and 48 hours, and then sort of starts to wane off. So works quickly, and then the effect continues up to 48 hours. So there's a durability as well as an early action, which is inbuilt into the treatment. Now, how does it compare with the effect of triptan? Because that's the main comparison, right? I mean, we are looking at Nurtec or rimegepant, and looking at it, how does it compare with the existent treatment with triptans? So this is data from pooled analysis of 3 double-blind randomized placebo-controlled multicenter trials. And in this, we are looking at patients who were triptan naive and comparing them to patients when they were put on rimegepant. Then we are looking at another group who were using triptans, and then we're looking at people who had failed one triptan, and then we're looking at another group who had failed 2 or more triptans. And we're trying to figure if the response to rimegepant is different in patients who are falling into these different categories. So if somebody's triptan naive, are they behaving differently when they're giving rimegepant compared to somebody who's currently using triptan, or those who have, for example, failed a triptan? And what this study is basically showing is that people who have triptan failure, or who have a history of triptan failure, even in those people, it is equally efficacious. So you can use rimegepant in people who are currently taking triptan, who failed a triptan, who failed one triptan, who failed more than 2 or more triptans, and who've never tried triptan. The medication seems to work equally well across the board, no matter what the profile of these patients is. Okay. So based on this data for the acute treatment, the American Headache Society then came up with this consensus statement where for mild to moderate attacks, still recommended that you can use non-steroidal anti-inflammatory drugs and non-opioid analgesics and acetaminophen. But for moderate to severe attacks now, migraine-specific medications where triptans already had a place, but now you also have small molecule CGRP receptor antagonists, and GPANs are amongst them, and rimegepant is one of those medications. They are now included here. Should there be a specific criteria for initiating GPANs or ditans? Well, they should be, ideally, the recommendation is prescribed by licensed physicians, and they should still be used by patients who are 18 years of age or above and who have been diagnosed with migraine, and it's approved for both with migraine with or without aura, and also for chronic migraine. Either contraindication or inability to tolerate triptans or inadequate response to 2 or more oral triptans as assessed using a validated acute treatment patient-reported outcome questionnaire or clinician attestation. All right. So how does one GPANT compare to other GPANT or ditan? Well, the big advantage of rimegepant lies in its half-life. So a little bit about the pharmacokinetics of the medication. It has a longer half-life compared to ubrogepant, for example. And because of that, it requires a less frequent dosing. And that's why it's given every other day. It also has an onset of action that's earlier. And because of that, it may require fewer dosing intervals. So it has a better pharmacoeconomic profile as well. You may require fewer pills of rimegepant if you have to control migraines over a longer spectrum. Okay. So moving on to the preventive aspect of rimegepant, which is the other interesting study that we are going to talk about. So looking at this profile that, the half-life is longer, the sustainability of the effect was seen in this acute study, the effect was 48 hours. And the other interesting thing that was seen in the previous study was that patients who were taking for abortive treatment frequent rimegepant, their total number of monthly migraine days had started to come down. And it was this observation that led to the belief that rimegepant could be used as preventive medication. And that led to um, this particular study that we are going to talk about now. Now, there were, of course, the preventive therapies that were available also had their challenges. There was the previous medications that we were using. We all know that when we put people on the older medications that we talked about, it takes some time for us to sort of build up um, on the dosages. There's a titration period that a lot of these medications have for the oral preventive ones that are the older medications, and some of these may have poor tolerability. There's a potential for weight gain. There may be cognitive issues with some of these medications, fatigue and those kind of side effects may be there. And then a lot of times people have a tendency to discontinue these medications because of some of these side effects. And we have data to support this sort of patient behavior as well. Another issue is for women in childbearing age. A lot of times there is this concern that they will not be able, if they start to conceive, what will they do then? Then how will they will have to stop all medications, and what if I suddenly become pregnant? Then what's the risk of teratogenicity? And then monoclonal antibodies, of course, we know that they were such a big game changer in terms of the efficacy of the medication and the drastic improvement in migraines that came with them. The only concern that remained was that these medications also had long half-lives, and because of that, we were sort of, we knew that they would take time to sort of wash out from the body after the treatment is stopped. So, so for example, 34.7% of the patients who were receiving 6 months of adalimumab, another concern was that they were reporting that there was a wearing off response in the week before the next injection. So this is something that I saw very commonly when I started to use adalimumab, that in the 4th week in particular, patients would start to get breakthrough attacks of migraine. So this wearing off response was something that patients started to report. And then, of course, still very much in our population, we still see patients who have needle phobia. They don't want to get injectable medications. So these were some of the things that were still, creating the niche for medications other than the injectable monoclonal antibodies, although they were a big game changer in the entire repertoire of medications for migraine that were available to us. So then came this study for the preventive role of migraine. And this study was basically done between November 2018 and August 2019. Around 348 patients were randomly assigned to rimegepant, 75 milligram, given every other day. And an equal number of patients, almost 347, were assigned to the placebo arm. And obviously also given every other day, since it was a blinded study. And they were basically reassessed at weeks 9 to 12. The primary endpoint, the baseline monthly migraine days in the active arm or the rimegepant arm was 10.3. And it was 9.9 in the placebo-treated arm. The monthly migraine days were the reduction in monthly migraine days from the baseline was the primary efficacy endpoint. So the mean change is what they were measuring. And what they found was that there was a significant reduction of 4.3 days from baseline during weeks 9 to 12. So so they continue to take it for about 3 months, so for 12 weeks. And in the last 4 weeks, so weeks 9 to 12, so they compared this to the baseline. And they found that there was a significant reduction of 4.3 monthly migraine days compared to 3.5 monthly migraine days in the placebo arm. And this difference was a significant difference. Another interesting thing they found was that with rimegepant, there was a very rapid onset of action, and 30% reduction in weekly migraine days started in the very first week of treatment with rimegepant. So quick action, and by week 9 to 12, there was a significant difference between the rimegepant arm and the placebo. Again, placebo arm, of course, also did show benefit, which is something that we see across the board in all headache studies, migraine studies. Now, this is interesting because this is now the open label extension of the study. So the double-blind treatment arm finished at 3 months, but then the open label extension period continued up to 16 months. And in this, basically, what they were looking at is whether this effect was sustained. So was it just that 3-month period where they saw that effect and then it would wear off, or is this effect going to continue? And what they found was that the overall mean reduction from baseline in the number of monthly migraine days averaged over the 6-month treatment period even lower. So it was 6.2 days. So initially it was the 4.3 days, and overall they continued to have further improvement in the headache control, and the difference from baseline increased to 6.2 days difference of reduction in the monthly migraine days. So the effect was actually the efficacy continued beyond the initial drop that was seen with rimegepant. Okay, this brings me to the third trial, which is a head-to-head comparison that was done between monoclonal antibody and rimegepant. And I think that was a very, very brave study. Seldom you will see a head-to-head comparison of one active medication against another active medication. Very few studies attempt this. Very rarely you will see this sort of thing in multiple sclerosis. Very rarely you would see this in migraine. Usually it is against a placebo that most studies are designed. But this is one such study, the Challenge MIG study. So in this particular study, it was a phase 4. So phase 4 because both these medications, galcanezumab, which is a monoclonal antibody, is already marketed, and rimegepant, which was also already marketed. So both are post-marketing. It was double-blind, randomized, double dummy trial. So double dummy because both arms got an injection, and both arms got the orally disintegrating tablets. So the arm that was receiving active galcanezumab got the placebo, which was the orally disintegrating tablet, and the arm that was the active rimegepant got the placebo, which was injectable placebo instead of the galcanezumab. So double dummy because of that reason. And it was a beautifully done study. So there was a screening phase that lasted between 3 to 30 days. There was a clinical assessment that was done. A washout period was given. And there was a bunch of excluded medications. There was a list that was given. To make sure that these patients were quite clean of any medications that could potentially affect the results. And then there was a prospective baseline study of 30 to 40 days, in which the patients were prospectively recording their daily headache data in an electronic diary. So this data basically provided their baseline headache activity, how frequently they were getting the headache. And around 580 patients were then assigned randomly in a 1:1 ratio to one of those two arms. So initially, with galcanezumab, you have to give a double dose the first time. So a 240 milligram loading dose was given sub-Q monthly. Plus, they were put on a placebo. So this rimegepant orally disintegrating tablet every other day. And then in the other arm, the rimegepant 75 milligram was given every other day, plus the placebo sub-Q monthly. So in the first go, it was the 2 placebo injections were given and then monthly 1. And this treatment was continued for 3 months. After 3 months, the primary endpoint, which was the percentage of participants who had experienced at least a 50% reduction in monthly migraine days, were measured. And then there was a bunch of key secondary endpoints which were also, measured alongside. And this was the end of the study. So the end of treatment period was here. It was a head-to-head study, and I'll show you the results in the next. The patients could not take a GPANT. They were not allowed to take it for acute migraine treatment during this treatment phase, because obviously that was the idea. Now, it was designed as a superiority head-to-head trial, and galcanezumab basically, so both arms basically showed that almost like equal number of patients had more than 50% response with the treatment. So 62% patients had more than 50% response in monthly migraine days in the galcanezumab arm, and 61% had it in the rimegepant arm from the baseline. So from their own baseline, patients were being measured, and more than 50% response rate in monthly migraine days in both arms. So no statistically significant difference between a monoclonal antibody and rimegepant was seen in this challenge mix study. All right. What about serious adverse events? So this is again also interesting data. There was only one serious adverse event that was reported in this study, and that was a pulmonary embolism. Turns out the patient who did have a pulmonary embolism was in the rimegepant arm, and he or she did have a prior undisclosed history of PE. However, the event was considered by the investigator to be related to the blinded study intervention, so it was reported as such. There were other treatment emergent adverse events, and they're listed here. So nasopharyngitis is something that you will see being reported in these monoclonal antibody studies as well, also in the GPANs. In the range of 1 to 2% in most of these studies. Nausea, fatigue, injection site pain, sinusitis, constipation. So everything seems to be in the range of less than 1%, most of these, and most of these are minor adverse events. Nothing major is reported in terms of side effects in this particular study. Okay, so what about, so I'm just going to go back a little bit to the long-term extension study from the prevention trial, just so we could go over some of the adverse events. This is again the extension arm of that study, just to show you again the adverse events that were reported. Majority of the adverse events that have been reported in these long-term follow-up studies have been mild or moderate in intensity, and they have been judged by the investigators to be unrelated to rimegepant. Very few patients had to discontinue the study drugs in these, so safety data looks very good. less than 1% of these adverse events were considered by the investigator to be related to the study drug. And you see that most of these adverse events in these extension studies also are very minor: nasopharyngitis, UTI, influenza, back pain, bronchitis. This mainly has to do with the presence of these receptors in other parts of the body, and that's why it's being caused. These side effects are somehow related to this. Again, cardiovascular risk profile is very, very good for most of these GPANs and also for Rimegepant. So safety data is very good in terms of cardiovascular disease. Okay, now this is interesting. What this slide here is showing that what this is showing is that as time passes, the proportion of patients who end up with more than 50% reduction, or more than 75% reduction, or more than 100% reduction continues to rise in proportion. So with continued use, the actual benefit does not wear off, but the percentage of Rimegepant treated patients continues to, the number of patients continues to benefit more and more. Again, the sustainability of the medication and the relief that the medication continues to provide grows as the medication continues to has a protracted effect and has sustainable effect. This here is basically again showing you the patient's preference and satisfaction with the medication. This is showing you the participants who are preferring Rimegepant week 12 and then later in week 52, and the preference basically is more than 50% compared to what their previous migraine medications are. So this is just some participant or patient level data which is supporting the use of Rimegepant. This slide here is basically showing you some of the clinical attributes. This is a network meta-analysis which is comparing Rimegepant with other monoclonal antibodies, and it is showing you that the effect is comparable to other monoclonal antibodies. The medication has excellent tolerability. The short half-life, the fact that you can just, these medications have longer half-lives, so there is a concern for, childbearing age group for women. So that concern is laid to rest. You can put these patients and, within less than 48 hours, you can easily, if a woman finds out, she can just not take the next dose and she's good. There is no attenuation of effect. I've just shown you that long-term data, and the sustainability of the effect is there. So, and then of course, it's a very convenient administration route. So again, for a lot of patients, the injectable medication is not such a good option. So for those patients, a simple orally administered medication is an excellent idea. Side effect profile is very good. I've already shared that with you. And then the washout period, yeah, we talked about that also. So previously, migraine toolbox used to look very complex, bunch of medications, something to abort, something to take later as rescue now, and then of course something to prevent. Now it's all in one pill, and it's going to work both as an abortive and a preventive medication. So my personal experience with Nortec has been very good. I suffer from migraines a lot, so I can tell you that it's worked very well for me. I haven't used it as preventive because it seems to work well for situational migraine. It's worked very well in my patient population for Ramadan. It worked very well. because in Ramadan, a lot of patients suffer, especially in the first week or 10 days, when you're getting used to the fasting routine, people tend to get a lot of migraines. So it's a good medication to start off the Ramadan as your body is getting used to it. And I've tried it, and it really worked very well for several of my patients during that time. For perimenstrual, premenstrual migraine, it works. It's worked very well for those kind of situational migraine. I have a couple of patients who get migraines when they get, they travel. So it works very well in that kind of situational migraine sort of situations. It's a good choice for those kind of situations. And I think I can leave you here. I don't think I have many more slides to add there. Okay, that's it. Thank you.
Thank you very much, Dr. Maria Khan. This was very thorough and updated clinical trials and evidence for rimegepant in acute and preventive care for people living with migraine disorders. And thank you for sharing your own experience. It's always nice, possibly when you try something yourself, then it gives you confidence when using it with patients. I have a few questions. We have possibly 7 minutes for questions. There were a couple of questions. What happens with the old medications? Do you still use them, or do you go from the beginning now with rimegepant?
So it's just that our repertoire is now bigger, but no, it doesn't mean that we don't use them at all. We definitely have our profile of patients where we do use them. There are patients who would require sometimes combination, other conditions where you would want those combinations to kick in. So, for example, you might have patients who have epilepsy and you want to use one medication that would work for both, for example. I have a few patients who have essential tremor. So, propranolol and would work for both essential tremor and migraine. So those cases, of course, they're not uncommon in our practice. So that. And then, of course, a lot of these medications are not approved in patients less than 18. So that group, of course, is there. And then we are gaining more confidence in terms of using some of these medications as first-line medications. But cost is still an issue.
Yes.
Is still an issue. So
Yes.
if insurance is not covering, then yes, we do very often go to our good old medications, which we've used,
for a long time before we had these.
Yes, and we have ample experience with them.
Yeah, and I have a question here asking about how does the medications dosing regimen differ between migraine treatment and prevention? We know that this is one medication that can be used for both. So our guest or our attendee is asking how and how does it differ, and what are your challenges associated with adherence to rimegepant?
Yeah, so that was one of the questions that I had also asked one of the migraine experts, the people who introduced the medication to us, how do you remember to take a drug every other day? Every day is a different matter, but every other day is more challenging. So his answer was that if you get a response to a treatment, then you pretty much remember to take it. You pretty much remember to take it on the day that you need it. that's something I've seen that people don't usually come back to complain about, that they kind of forgot about it. So the way that the dosing differs. So for abortive treatment, you just take it pretty much when you need it. So at the onset of headache, it's just one pill that you put on your tongue, and it's an orally disintegrating tablet. For preventive purposes, it is taken every other day. So once in 48 hours. You should not be taking more than 18 pills in a month. So that's the basic label for the medication. Generally speaking, if on top of every other day, if you are requiring additional abortive treatment, there is no concern if you need to take an additional, triptan in between, or another non-steroidal for an attack in between. There's no concern for you to go ahead and take that as an abortive treatment alongside.
And the next question I have is around, what about the injectable CGRPs and Nurtec? Do you have any experience for someone who takes once a month injection and then Nurtec when needed? Do you have any experience with that?
My own experience is with a few patients, but there's a larger series that's published from another colleague from Abu Dhabi. Of close to 200 plus patients, combining monoclonal antibodies and GPANs, and there are no safety concerns.
Yes.
There's a very interesting study where they've looked at why this would work. So the way the monoclonal antibodies work is they're also blocking the same kind of calcitonin molecule. So when you give galcanezumab, for example, there is a reduction in the amount of calcitonin that you get. So the first time that you give it, there's a huge reduction that you see. So that's why you give a big dose to get that big boost. And then with the next dosing, there's a further reduction. But you still have a lot of circulating calcitonin molecule in the body. So that additional GPANT might actually be beneficial, and that's why this combination may work. And they've shown it at a molecular level. There's a good study that's been published to show at a molecular level why that might work. And there were no safety concerns in that study as well. So there's good data to support that combination might work, and the safety concerns were not raised in that study as well.
And I possibly, because I'm not practicing in the UAE, the guidelines, the UAE guidelines that came out a couple of years ago, where do GPANs sit in these guidelines in terms of, are they first line?
I'm not so sure that they're there quite yet. I think they might be updated soon to sort of include more, because now I think we have more of the GPANs coming in now. There are others now that are available in the UAE.
Okay, but the CGRPs are the ones that are in the guidelines, but not the GPANs?
Yeah, that's what I think. I may not be updated on that, so please don't quote me on it, but I think monoclonals were definitely there, but I'm not so sure if all the GPANs are there or not.
Okay, and last but not least, if you would like to give us any advice on any side effects that you see with ubrogepant, and how to anticipate them and counsel the patient and advise them ahead of time. Do you see anything that you feel that we need to think about?
In terms of side effects with the GPANs, not really. I mean, in terms of side effects, I mean, these are amazing drugs, to be honest. I mean, maybe a little bit of sore throat, those kind of things, which are very non-specific, which you could put with other things as well, So I'm not so sure if you could pinpoint and say that this is the medication that led to it. I mean, nausea could pretty much come with my migraine. So I'd have trouble saying it's because of the medication or because of the migraine itself. It's sort of like that, nothing so specific that I would kind of point towards the drug and say that the drug did it, sort of, so.
So this is easier, I guess. I guess very easier to follow up
with these new medications generally.
Dr. Maria Khan, thank you very, very much for this presentation, for sharing your personal experience and your practice with us on using these medications. This migraine masterclass was sponsored by our very generous sponsor, Pfizer, who have been sponsoring us for since the beginning, and we're very grateful and thankful for them helping us bring science to our attendees. For everybody who has joined us tonight, I would say thank you very much. Thank you for the engagement, thank you for the questions, and we're very, very happy to see you again. Looking forward to seeing you next time is going to be June 14th. The same time, it's going to be 8 to 10 UAE time, and that's going to be, I think, 12. I think it's 12 to 2 Eastern time in the US and Eastern Canada. The next session I think you're gonna like a lot, because I see this also in my practice all the time, and that's comorbidities, and it's very specific to psychiatric comorbidities and anxiety, and I think that this is something that you will really, really like, because we see this all the time, especially anxiety and depression with people living with migraine, and it's always something that we see in our practice for people, especially those who have had it for a long time. As you can see on our screen, we have the IVPN library. We have a large library with a lot of subjects on neuropsychiatry. So not only on migraine, you will see a lot of the old recordings. The Association of Migraine Disorders also offers a vast resource kit that you can go to their library and look at podcasts, patient information, interviews, whatever you need, you will find also there. Together, I think we provide our followers with the best information and the latest information on migraine management. Special thanks to the Association of Migraine Disorders and IVPN. And of course, behind the scenes, if I forget, I think I'm sorry, but I always want to say thank you to the people behind the scenes. We have Dr. Usama Tabara, who has started this, bringing this science to us around the world, and linking everybody to the best information on the clinical and also even the best speakers from all over the world on these subjects. I have Kylie Petraka, who is very, very dedicated, and in the chat, if you see all these resources, it's compiled and curated by Kylie Petraka. Thank you very much. I have Maya Zainuddin, who's behind the scenes, always running and trying to find the best speakers for you and the best subjects to bring to you. And last but not least, Hussam Salamat is from Amman, Jordan, who has been always behind the scenes, but doing the majority of the work needed for us to bring this to you. Thank you very much. Have a very good night. And we hope to see you. Dr. Maria Khan, thank you very much. I know it's late, but we really appreciate you being with us tonight.
Thank you for having me.
Bye-bye.